Good morning, everyone. My name is Umar Kabo Idris on behalf of Community Health Impact Coalition Group that actually came up with the idea and developed the National Georeferenced Community Health Worker Master List, which is going to be hosted in a registry. And I'm here together with Margaret Odera, who is from Kenya, and Dr. Nana Sanda Maimuna, who is from the Ministry of Health in Nigeria, and work with National Primary Healthcare Development Agency. Before we start, I would like to give a few bio of who Margaret is. Margaret is actually representing the community health worker, and she's going to speak at the end of the conference on mainly the perspective of community health workers. She is a community health worker and a mentor mother. She works at Mother Care Matari North Health Center, near a health center close to her place of residence. She spends her days sensitizing and mobilizing community members on many assigned health care programs, including emergency response, to have a better health in her community. She's very passionate about that. She also conducts psychosocial support to her community groups. Margaret also mentors HIV positive pregnant and lactating moms to eradicate mother-to-child transmission of HIV. So she would be here with us, and she will be speaking after I finish the explanation of the implementation support guide. Also, we have with us Dr. Nana. Dr. Nana is actually working with the Ministry of Health, but she is in the agency of National Primary Healthcare Development Agency. She's the program manager for a program called CHIPS. CHIPS actually stands for Community Health Influencers, Promoters, and Services Programs. She works with the National Primary Healthcare Development Agency, which is a parastatal under the Ministry of Federal Ministry of Health. She provides national oversight and coordination of the implementation of the CHIPS program. The CHIPS program is a platform for harmonizing of existing community level interventions and personnel, which is the community health workers. She is passionate about strengthening the community component of primary healthcare in Nigeria, and she really believes that properly selected, trained, kitted, empowered, and supervised community-based health workers are key to the achievement of universal healthcare coverage in Nigeria. So I'm with very important personalities who actually believe in community health workers, who are the bedrock of primary healthcare development in general, for us to achieve the universal healthcare coverage goal. The development of this national geo-reference community health worker master list hosted in a registry is actually a guide for us to, as countries, to look at and emulate for implementation in the nearest future. Apart from being initiated by our group, this was really developed by Clinton Health Access Initiative, popularly known as CHI, Community Health Impact Coalition, the Global Fund, Health GeoLab, Living Goods, and UNICEF. Obviously, community health workers, the cadre of community health workers is largely challenged by, the accurate actual count on the number and location of community health workers. To a large extent, it's even often unavailable. And according to WHO, there are over 3 million community health workers globally. And of this number, this was largely compiled from national censuses, labor force surveys, and other surveys like the National Health Workforce Accounts And this data is only available from 75 countries. You know, we have 195 countries. You can imagine only, you know, about 61% of the rest of the countries in the world, you know, are not really represented. And this reference data is between 2000 and 2019, which of course is approximately 19 years. And what even makes it worse is the most recent data of these 40% countries is more than 10 years old. So this is really a huge challenge, particularly around, you know, the recency of the data and what have you. Also, because of this unavailability, there are so much uncertainties, particularly around the number allocation of this community health worker, which may likely prevent or delay the planning and implementation of several community health services. And we actually saw that during the, you know, the first period of the COVID-19 pandemic. We saw where, you know, a lot of health workers globally and doctors were actually infected because they could not actually have PPEs. So part of our initiative at that particular time was to see how we can, you know, protect community health workers, because that was our key interest. And we realized that, you know, there were multiple community health worker lists with unclear source of truths. So you could have even you know, people collaborating agencies, the government, you know, other admin and planning units, HR units, they actually have their own master list, which does not really have the total number of community health workers, even at subnational levels. Their locations is not really captured. Then you have a lot of multiple lists around admin and planning units, HR units, you know, disease-specific programs. You could have different lists for malaria program. You could have different lists for polio program, and the list goes on. Also at emergency operations centers, where planning and strategic meetings happen to quickly deploy community health workers for different specific programs or outbreak responses. There's a lot of issue because, you know, there's delay in terms of cleaning the list, harmonizing it with what is actually existing between different organizations, agencies, and the government. So that actually takes a lot of time. You know, also around community health worker payment, you know, you would actually want to validate where a particular community health worker worked and, you know, try to pay that community informant with the location and performance of where the person actually works. But because there are a lot of this list out there, there's need for consolidation, and that takes time to delay planning and implementation of critical activities. In terms of also health services accessibility, you would have delays because you need to now do harmonization and a lot of other processes to ensure that you have a master list that is actually workable. So similarly, there's no actual visibility. And for us, lack of visibility into this very important workforce, it impedes the progress towards the effective institutionalization of community healthcare worker cadre. And this is a very, very important cadre that, you know, without it, I think a lot of health activities at the grassroots and community level cannot actually be executed. Another big issue is, you know, yes, you could actually have multiple lists for different purposes to actually meet the needs, for example, of human resource for health need for a particular, you know, purpose or program. So lists are being generated mainly to address those kind of challenges. So for example, to ensure that, you know, payment is actually being done or salary is allocated for budgetary purposes. For planning or recruitment and training, you need an active list. So all these lists might actually come, but they would not be, in so many instances be georeferenced or maintained over time. So it's just a one-off something that would actually not really be sustained. And we have recorded a lot of examples in terms of operational challenges, one of which we also encountered was during the heat of the pandemic. Our group actually came to see how we can mobilize PPEs for community health workers. But we were all challenged by, asking our ministries or subnational offices on the total number of community health workers for us to actually see how we can mobilize PPEs to them. That was what really, gave birth to this particular initiative. We brainstormed and saw that there was actually a need for us to, develop this operational, implementation guide to see how master list can actually be generated in a coordinated manner and then can also be hosted on a registry. Because, ultimately you would have issues around, some of these programs are actually being done for the purpose of, one-off programs, and then you would have to come, if you have an HMIS system, you would come back and say you want to actually update it, and it slows a lot of payment processes or even supportive supervision, which is a very important aspect in coordinating these kind of activities. So the solution for us is actually to develop this master list and registries to contain them, so that we can ensure this community health worker master list is actually kept up to date and shared appropriately. And what do we mean by actually a national community health worker master list? From our own research, and what we came up with is actually a list with a minimum content required to effectively enumerate and track all the community health workers in the country. So what we're saying is the minimum content is for us to have a list that is working for your own country, but that list is just a simple line list, which is listing all the community health workers in a particular country, and with minimum data elements, as minimum as the individual's name, which is the health worker, and their location, where they are actually residing or where they are actually working. So for example, are they working in a particular community, health post or primary healthcare center? So that should be identified within the master list. Also, what we mean by the registry is actually a platform, which is an IT solution that allows, governments, ministries to actually have an IT solution that allows them to store, manage, validate, update, and at their own time, share this master list across multiple programs and information systems. And that is where the flexibility comes into play. We are not just trying to reinvent the wheel, but bringing in something that would actually have the capacity to integrate with other existing systems. And the beauty of this is ministries can maintain, update, and share information in one-stop single place, more like a one-stop shop where you can have all your lists together and you can share them as the need arise, maybe for example, during programs and emergency or outbreak responses. So this would actually replace the tons and thousands of Excel spreadsheets that we have around for different programs, different units, and different purposes. Or to some extent, in some countries where you have paper files still flying around, now you have something that is actually being stored to help you and guide you to have a central system. And one of our key goals is for this implementation guideline is to actually support national governments, their own technical and financial partners also, to have some sort of functional, continuously maintained, shared, and a particular institutionalized community health worker master list, which is going to be hosted in a national registry. And we identified 4 key objectives, and those objectives are actually speaking to, which I would actually present in the next slides, is about, describing the principles of this particular georeferenced community health worker master list. It is very easy for you to describe where you are, and then we have steps to take you through to generate, share, and maintain this in the particular registry. It is also coming to complement other systems. It is also going to be as flexible as possible to function as also a living document which evolves over time, as flexible as it can be. And we recognize that technology can actually also evolve. So the registry should be able to also accommodate such future happenings. It will also be good to talk about, the development process of this very important document. Like I said, it was initiated to respond to PPE needs, particularly for community health workers. And we realized that unless we know their count, unless we can count them and identify their location, there's no way we can actually distribute these PPEs, especially at the time of need, where the whole world almost came to a stop for us to respond to COVID-19. It was jointly developed by CHIC, the Global Fund, Health Geolab, Living Goods, and the UNICEF. A lot of consultations actually happened with several ministries, particularly Ethiopia, Kenya, Mali, Rwanda, Sierra Leone, Togo, Uganda, Zambia, and like I introduced Dr. Nana, she's from Nigeria Ministry of Health. Consultations are also ongoing. And also Burkina Faso. Just during our last call in preparation for this meeting, we were told that Burkina Faso is already ahead of other countries. They have already started implementing the use of this particular guidance, which is a very good way to go. Other countries are also in the pipeline. Before it was actually unleashed or completed, we seek technical expert guidance for them to revise. And these technical experts came from different fields, nearly 50 organizations, including those that are core implementers, those from the academia, donors, and other UN agencies. Also, we had a very good endorsement from the Africa CDC. And I must say, we again thank the Africa CDC for giving us this opportunity to unveil for the first time this guidance to everybody before the official launch, which is scheduled for January 20th next year. Like I mentioned, we sat back and, recognized that we needed to actually understand the global enabling factors. And that was why we consulted with countries. We gave out for revision from the academia and technical experts before actually unveiling it. At that level, we also developed guidance and minimum standards for community health worker lists and registries. We also tried to align funding streams to support the harmonization of this particular community health worker activities. And also, very importantly, to promote information sharing within the country. And then we came down to the country level. At the country level, our aim was to see how we can actually, guide countries to institutionalize this strategy. At this level, we looked at 7 steps processes. and they are very straightforward and easy to follow for sustainability at the end of the entire process. At the beginning, in step one, we actually advise that countries should actually, you know, assess their current situation, where they are in particular. So we understand that people, current processes, and technology is actually largely involved. So the maintaining of data, so what we're saying is, first you need to identify your current state. You look at your processes, you look at your technology, what is actually being used, you know, before you embark on the journey. And then the second step is talking about the governance structure, you know, leadership, definition of roles and responsibilities to actually, you know, go on to the third step, where you define, you know, the state definition target. Who are your partners? You know, who is going to get access? How do you define your SOPs? And then the fourth step is actually very important, where you're looking at what is currently existing. Do I have multiple, you know, master list of community informants? If yes, you look at them and see how you can actually harmonize if there's need to do that. If there's need to also collect data to fill in those gaps, then this is the step that you know, countries should actually look at before generating the list. The next step is establishing a community health worker registry, which is actually looking at the technical set of registry to host, you know, the identification of hierarchies, who is getting access, and why. And then you have the level of sharing this master list. And then you also have the sustainability aspect to it, looking at how you can secure resources for sustainability purposes. How are you going to update this list, how the frequency, and what have you. In addition to that, we adopted a model, which is the maturity continuum, you know, and then we identified 4 key domain areas for us to be able to actually develop a community health worker master list hosted in a registry. You need to identify, following those steps, where you are. You have to you know, identify the use case. And if you look, maybe at the master list level, you could have already been at the yellow zone, where all you need to do is, you know, maintain, regularly update, and then harmonize and harmonize that. So basically, those are the key things that the guidance is really talking about. And in terms of data to be actually collected, there are examples globally around what kind of data is being collected for community health worker master list. So depending on what data a country needs, really, you know, our minimum criteria to recommend is at data elements level is for community health worker list to have a kind of uniquely identifier, where you have the name of the person, you know, the gender, and then the location of the person. So those are the key data, minimum data elements that we are advising countries to adopt. And we have highlighted questions as to how you can develop and understand what exactly you need. For example, one is what is the minimum set of data elements to be included in your community master list? You are going to sit down and identify what exactly is needed. But for us, it should be a data that one of the elements should actually be to uniquely identify and to be able to locate where the community informant is actually coming from, particularly georeferenced. And for this to be very, very adoptable, we believe that as technologies emerge, there's always room for interoperability. And that would only allow systems to work. If you already have reach that level, then right from planning stage, the health worker registry should be able to actually, integrate with other services like for countries that have health facility registries and other registries and other point of service applications. Also, a very popular one is one of those business domains that a lot of countries use, which is the logistics management and information system, LMIS. So what we're saying is the registry should be able to be complementary to these other services in terms of interoperability. And at the end, what we're saying is how can ministries actually use this guidance? So like we have explained, very importantly, countries need to identify at that maturity model where they are. So that would actually ease a lot of processes because some countries are already far ahead and others need to start from the beginning. So if you look at the maturity continent, you would already know exactly where you are. And then you can now move towards institutionalization. And then the national georeferenced community health worker master list can actually be actualized and hosted onto the registry. Also, the 7 steps process we explained also, if they are looked at, it will actually ease the process and the operation strategy for you to be able to establish, share, and maintain the list in a registry. Also, the guidance would actually inform policy, a registry that can be included with national strategies for community health worker, for community health, universal healthcare coverage, or actually health security. So this is the unveiling of the implementation guidance. Thank you very much for listening. I would now, step back and welcome Dr. Nana from the Ministry of Health, particularly from National Primary Healthcare Development Agency, to speak about how they can actually implement this, especially around the CHIPS program and other primary healthcare initiatives. After that, I would also bring in Margaret Odera to also talk about the perspective of community health workers, especially from Kenya. Then we would listen to questions and comments. Thank you very much. Dr. Nana, please.
Thank you very much, Umar. Good afternoon, everyone. And thank you, Umar, for this very interesting development from the National Primary Healthcare Development Agency. We welcome the development of the community health workers master list. In Nigeria, before 2018, community health programming has been a majorly neglected area of primary health care. And we all know, just as Umar has said, that if we do not strengthen this component, it will be difficult to achieve universal health coverage. So the Executive Director of National Primary Healthcare Development Agency, Dr. Faisal Shoaib, conceptualized the Community Health Influencers, Promoters, and Services Program as an attempt to strengthen the community component of PHC. What this is looking at is providing a platform to coordinate all activities in that area. The challenges that affected community health programming had been having different categories of community-based healthcare workers. We had verticalization, different trainings, multiple pilots, and basically all that brought about the development of this health worker policy. And towards institutionalizing community health programming as well, the Federal Ministry of Health has developed a community health policy. That's the National Strategic Framework for Community Health Policy, which provides further guidance to ensuring that we strengthen community health programming in the country. To make this a reality, really, we need a vision which has been provided by our leadership. We need commitment and political will by all stakeholders. And then we also need the right resources, from the human resources, which that's our community health-based health workers, which should be rightly nominated, trained, and deployed to provide the services, the right services where they're needed at the right time. Then also, we also need the right financial resources. And for that, in Nigeria, we have looked at ensuring sustainable financing, and that is why we have the Basic Healthcare Provision Fund that part of has been dedicated to the CHWML program to ensure that our community-based health workers are supported and motivated to provide the services at the community level. Then we also need the right material resources. And this is where really we're excited about the community health workers master registry that Umar just spoke about. Because for the CHWML program, our strategic direction is to increase geographic coverage to quality community-based primary healthcare services by scaling this up across every ward in the country so that all the hard-to-reach rural populations enjoy the services of community-based health workers. And secondly, we're looking to improve quality of services by promoting innovation and leveraging technologies in service delivery, in human resource management, capacity building, and monitoring and evaluation as well. So with the community, with a georeferenced community health workers registry, this would make, this would be a veritable tool to ensure that we bring that, we leverage that technology to achieve this. Of course, we also need another strategic direction is improving availability of essential drugs and medicines and other supply. And we've seen from Omar's presentation that the registry will make that possible. And lastly, we also need to strengthen program management and coordination to achieve the overall objective of the CHWML program. So for the National Primary Healthcare Development Agency, we have used the GIS, that's the Geographical Information System, during the polio eradication program. And that was really helpful in eradicating polio. Micro-planning was an essential part of this. The use of the GIS technology for mapping and to deploy and track vaccination teams was quite helpful. So presently, what we have is that once our community health workers, as the CHWML agents, have been trained, the first activity is community mapping. And this is presently done using hand-drawn maps to show the distribution of settlements and to assign households to the CHWML agents in their catchment area. So having this mapping would be useful to see the coverage, because this is what the technology would support us in doing. And okay, I think I will just speak a little bit more right now on the status of our list of community health workers. Rightly, those challenges that were listed existed, but right now we, as Umar said, use the Excel sheet to compile a database of our CHWML agents. And as we scale up, it would become really important to have this tool that we can regularly update and maintain a registry to track and support the payment and support planning for our program. So thank you, Umar. I think I will stop here a bit and let Margaret talk some more.
All right. Thank you very much, Dr. Nana. And that was really insightful, especially taking us around the CHWML program, which I was also very keen when it started. Given the updates has now given me a bigger understanding and the picture of what we have been saying. I think the last point you made was around the kind of issues we've been having with generating lists. And this is really timely for you to actually implement at that level and see how you can scale it up across the country, not just on the CHWML program, but across other programs. Like you highlighted, the polio program has actually opened doors for and left a legacy, if I may use that word. It has left a legacy for the public health community to actually appreciate and uptake technology, because like you said, just the mapping aspect of it has really uncovered a lot of settlements, and the bunch of the work is actually being done by community health workers. If this kind of initiatives are actually implemented, I think entirely would, go all the way to universal healthcare coverage, and we would have a very good health system. I would now bring Margaret Odera to speak from the perspective of community health worker, especially from Kenya. Over to you, Margaret. Margaret, can you hear us, please? Hello, I think we have missed, we have lost Margaret.
I think very quickly.
Okay,
about
please
what
come.
Thank you very much. Hello, can you hear me?
Yes, we can hear you. Please go ahead.
Okay. I would like to take this opportunity on the behalf of the community health workers to thank you because of this platform that you have given unto us. And this is historic. First of all, I would like to speak about how it feels not to be paid, to be formalized, or to be counted. At the end of every month, a community health worker submits reports just like any other health worker. But this any other health worker smiles away into the bank every end of the month, while the community health worker at the end of the month stays stranded, wondering how he's going to pay school fees, he's going to pay for the house, and this is so demoralizing for a community health worker. And yet, a community health worker goes on with her job with her head high above, as if nothing happened, because a community health worker is hopeful that something good is going to happen, a change is going to take place. 95% of community health workers are women. And as the saying goes, empower a woman, you will have empowered the whole globe. Formalization. Community health workers for a long time have been considered as informal. And this has really demoralized a community health worker. For example, our trainings have been very shallow and very informal. We are just given 2 or 3 updates for the year or for the month, and then we are told that that is a training, and that is not acceptable. A community health worker must be given a formal, detailed, and a tangible training, because we have proven to the world that we are up to the standard. A community health worker has not been counted. For example, last year, I went for the Prince Mahidol Award Conference in Bangkok. I was the only community health worker there in the whole of 77 countries. The other health workers were doctors and nurses, groups of them. But a community health worker, as I was very much lonely, I did not even have that person to connect with as far as my profession is concerned. And it clicked on my mind how a community health worker has been looked down upon. Maybe those doctors from other countries, those nurses from other countries, were the ones who are representing the community health workers in their countries. We can represent ourselves very well. A community health worker is a linkage, direct link between the community and the facility. We are at the basement there. So if we appear at the basement on the health systems, then why can't we be counted? I want to talk about employing the new community health workers. This is very important for us, particularly in Kenya. One community health worker represents 1,000 households. She has to visit 1,000 households as one person. When we employ other new community health workers, this will result in quality work, quality data, and quality health even to our nation. PPEs. A community health worker works directly with the community. A person who is in the community and is sick, the first person to contact is the community health worker. And community health worker sees that person when the disease is the highest, when the disease can infect another person very easily. If a community health worker is not protected, she is prone and she is vulnerable to being infected. And not only that, she will work also as an agent of cross-contamination between the people in the community and the doctors. Because when I go to the community, I speak to a patient, somebody who is sick. I can easily cross-contaminate that disease to the doctor whom I will speak to after I visit the patient in the community. So protecting a community health worker is not only protecting a community health worker herself, but it's also protecting the people who are around her and protecting the doctors and the nurses who she works with in the hospital. And it is also protecting the nation as a whole. Involving community health workers in decision making. It is very important to have community health workers involved in decision making. Maybe, just maybe, an idea from a community health worker is what we have been waiting for globally throughout. Maybe she is the solution to the problem that we are facing right now. We have been blaming each other up there, but maybe the solution is down there. I'm saying this because most of the time, complicated problems are solved with very simple solutions. So with this, I challenge the listeners to put money in community health workers master lists and to provide additional support and protection and urge the government to do so. We can't have global health security or universal health care if we don't count the community health workers. And for that, I want to commend each and every community health worker for the good work that you have been doing. We have been so patient. We have worked tirelessly, and that is a kudos and bravo for us. And I believe that something good is on the way. Thank you very much, all of you.
Absolutely. I think that was really captivating and emotional to some of us, especially those of us who are actually, going to the field to work very closely with community health workers. And I want to again echo what she said, particularly around unless health workers at community level are protected, nobody is actually protected. So thank you very much, Margaret, for sharing with us the perspective of community health workers. And, we also believe that with the evolution of this master list, eventually, once everybody knows how many community health workers are out there, formalizing them properly, institutionalizing them into countries, policies and processes, I think we would see a better look around the community health worker cadre. Thank you very much again. And finally, we'll take, we have been seeing very good chats, and most of them are actually talking about, the support of this initiative. I would like to answer two questions. One I have already answered from Charlotte Amadou, asking about will data protection policies need to be put in place? My response was actually absolutely. One of the 7 steps that we actually highlighted is the importance of data protection and security, including the sharing of the data itself. We actually understand that countries have their existing policies, and we encourage them to adopt, policies that actually provide data protection aspects to them, and also formulate new ones when they don't have or when the need actually arises. So, Charlotte, we actually recognize that data protection is a very, very important aspect, especially around IT systems, and that has already been put in the guidance for countries to actually adopt. The other question is actually talking about, first, Charlotte Amadou, okay, it's the same person actually saying it's a wonderful idea, but I wonder about several factors that need to go into the longevity of the use of this registry: hardware maintenance, regular software updates, training in use of this software, a helpline to offer assistance, and regular updating of lists. How will this feed into the implementation guidance? So again, that actually has been highlighted, particularly around those steps, and the model that explains where countries are or where they want to be also highlights the aspect of maintenance, regular software update, the training and use. So countries are actually advised to look inward, see what they're expected to do, but ultimately, like you actually said, is for this to actually work, it has to be sustained in the nature of mobilizing resources, particularly monetary, and we think governments should actually take ownership in actually doing those kind of things. Another question just popped in. 2 questions. One, what are the considerations for including informal volunteer community health workers in these registries, since they are not counted as formal community health workers. So what we are saying in general, Rosa, is because of these issues of informal nature, volunteerism and all, that is why we continue to have this kind of mess. So if we have a complete master list, it is flexible enough to be given updates, you know, and for each country, for example, they may actually have volunteer as part of their categories to embed in the elements of the data they are collecting, or add for formal and informal sector. That way, a registry can actually, you have a master list hosted in a registry that have some kind of control, you know, for when programs comes in, they can be assigned as volunteers, they can be assigned as informal workers, or they can be actually assigned as informal. So this is exactly what this registry and community health worker master list is trying to address. Also, the next question that was asked by Rosa was, how do we ensure that NGOs share their community health worker force data from vertical disease-specific programs in combination with government community health worker programs into one centralized registry? So obviously, those 7 steps classify from the beginning, where you're actually saying, where are we? You know, government needs to sit with this, with all the NGOs for different specific programs to identify, you know, completely bring your list so we can actually harmonize and ensure that we have one master list that can now have governance behind it, that can be shared. And we know these health workers, we know where they are coming from. Like we explained in the guidance, part of the issues is it delays planning and implementation. So when you have this, even in the era of, you know, pandemic, where you need to quickly mobilize community health workers to go into the field and sensitize people on, you know, outbreak that actually happens, you already have a list that can now go with it. And then you know exactly where you're going to actually get that. So again, it's about how these national governments bring in and pull all these resources together, bring in NGOs, partners, you know, even other ecosystem actors to actually come and, you know, participate and do this work, roll their sleeves and do this work, get a complete master list, and then host it on a registry. So thank you very much. I hope I have answered those questions. For more information, we encourage you and invite you to please join our official launch of this implementation guidance, which is scheduled to take place you know, on January 20th in a webinar that has been shared already with the group. So thank you very much for listening. And I think we have come to the end. Thank you, Dr. Nana. Thank you, Margaret. And thank you, beautiful listeners, for the session. Also those that actually asked questions. Thank you and bye for now.